Start. So my name's Chris Bennett. I'm Head of Communities and Volunteers at Sustrans. I'll be facilitating the webinar. So I'll first of all just like to introduce Dr Adrian Davis. Adrian is a very good friend of Sustrans and has worked with us for a very long time, at least 20 years, but probably more.
30.
And has spent the same amount of time working on transport and health, and is internationally recognised as an expert in that field. In fact, I was having a look through of his kind of major accomplishments and things he's been involved with, and it's really just a kind of roll call of all of the efforts to bring together transport and health over the last 20 to 30 years that Adrian has been involved with. He is currently working with the public health team at Bristol City Council, and also works with various universities, which
well, various universities will do.
So this is a presentation that was initially meant to be delivered at the Mode Shift conference, but Adrian was unfortunately unwell, so very kindly he's offered to do the session as a webinar. Okay, so I'll let Adrian take over.
Okay, well thank you very much, Chris, and welcome to all 51 of you at the moment that are listening in, and I hope you can see the screen, the holding screen, which is the health benefits of active travel. So I'm going to canter through really first of all the story about physical activity and why it's beneficial to health. I'm going to talk a bit about evidence and meanings of evidence, and then come into some concluding remarks before we open up to some questions. Right. So going back good 20 years plus, some of us started to look at what we thought were the ways in which transport impacted on health, both positively and negatively. And so you can see from the second slide, ways in which transport influences health, sort of scales there. Doesn't necessarily mean one weighs more than the other, so it is more important, but we know that of course there are the enabling aspects of movement, mobility, in order to have access, because access is what we need to have to people, to goods and services. But there are also the disbeneficial properties which have grown since the 1960s. If anyone knows the Buchanan Report, Traffic in Towns from 1963, they talked about injuries, noise and air pollution, and questioned air pollution as being serious at that time because the science was so poor. Now we have got a much broader understanding of the health impacts of road transport, and one of the most important impacts, negative impacts, really has been this understanding of the loss of physical activity, routine physical activity, such as through the commute, when we've transferred from physically active modes, and that includes combinations with public transport, to sedentary modes. And really, I think from a public health perspective, we talk about being in cars and vehicles where you're not having to use your own personal energy expenditure as sedentary modes, because they really do put our health at risk, particularly if we're at long-term exposure to them. So how does physical activity benefit health? Well, this is my one deeply scientific, medicalized slide, and I don't want to spend very long on it, but the greatest health benefits from physical activity are from its anti-inflammatory properties. Inflammation of any sort is bad for the human body. And when we talk about cells, the release of free radicals are the really dangerous thing which really start to destroy our cells and speed up the aging process, so that when we are physically inactive, free radicals are able to roam within inside the cell membrane and start to do damage to our cell structures. The increasing insulin sensitivity as a result of physical activity is really also important. We'll have heard a lot about insulin in relation to diabetes. So the lack of insulin sensitivity, which occurs as people become both pre-diabetic and diabetic, adds to significant risks of what we call all-cause mortality, death from all causes, and you can see that that physical activity prevents diabetes and actually can reverse diabetes. That's a really good news, and reduce the risk of cancers of many different types as well. The other thing, which is an interesting debate, which people get quite heated about, is about the importance of physical activity and weight management. So the physical activity clearly does play a role in terms of weight management, and many of us will know that from our own experiences of dealing with our own weight. But it's not the most important property, and there is still the old adage now that Stephen Blair in the US came up with: it's better to be fat and fit than to be thin and unfit, because it's about how well our cardiovascular system works. So carrying extra weight is a risk factor, but if you've got a good cardiovascular system, that will offset that. So that's about as scientific as I want to get in sense of going into the medical aspects of physical activity. I just want to give a bit more background now. So one of my great heroes, the grandfather of public health epidemiology, and epidemiology is really the study of how often diseases occur in different groups of people and why in societies. And Jerry Morris in the 1950s started doing research looking at physical activity, and at that time it was very interesting that his medical colleagues thought that what he was doing was really slightly mad, but Jerry persisted, and what he did do, and I just hope these slides will come up, yes, so the bus there is the key. So Jerry Morris first published a paper in 1953 looking at the difference between London bus drivers and London bus conductors, because you can imagine London bus conductors do, well, on average they were found to do 700 steps per shift, where the driver sat sedentary in generally his seat driving the bus. And the conclusion of that study, which was enormously powerful at the time and questioned though, was that the conductors had half of the coronary events of than bus drivers did, and that was controlling for confounding factors like diet and smoking and drinking, etc. So when Jerry produced that paper in 1953 in the Lancet, many of his medical colleagues questioned it. He then spent the next 10 years looking at studies of postal workers and others, so postal workers going out delivering the post on foot by bike compared to colleagues sitting in administration posts inside the postal service, and finding the same conclusions that he had for bus drivers and conductors. So that was a world first, and done in the transport sector, interestingly. Now I think one of the most powerful slides I ever get to show is this one, and if anyone's not convinced of the power of physical activity in general, then I think this slide is the one to show them. So we know that physical activity, really achieving the 150 minutes that chief medical officers around the world suggest, of at least 150 minutes of moderate physical activity, will reduce your likelihood of premature death by probably around 25%. But there are specific diseases that it will actually do more for you in terms of prevention of the risk. It doesn't necessarily mean you won't get those diseases, but your risk will go down. So this to me seems to be very powerful evidence that we all should be physically active, because we all started out life on the plains of Africa as hunter-gatherers, and we haven't outlived our biological destiny. So we should be physically active. It's just modernity which has taken away and mechanized many things in our lives, down to the electric toothbrush, so we avoid being physically active and burning calories. So a nice quote that I carry around is, I have two doctors, my left leg and my right, and the CMOs, the chief medical officers, have kind of put this into a easier format for us, that for most people the easiest and most acceptable forms of physical activity that can be incorporated into everyday life. Examples include walking and cycling instead of travelling by car, and of course stairs use instead of lifts. So we really do need to try to get back to be the physically active people we were before modernity and all its labour-saving devices are actually starting to make us ill. Another aspect that is important when we consider physical activity, particularly from a transport perspective, is there's something called a dose-response curve. Now, the dose-response curve, to a certain point, is actually quite linear. If you look at the box, you can see that from the ground, the red line, if it's a red line for you, goes up fairly straight, but starts to curve off at the top. We don't really need to worry about the top end, because some of us may be or feel we are near the top end, where that's getting towards the athletes. But the main benefits are to be housed in the two dotted line boxes. The difficulty for us in the UK is that a quarter of adults are right down in the bottom box. They do very little physical activity, so they are at greater risk of all diseases and premature death as a result. The important point about it, however, is that the greatest benefits will happen to those who are least physically active, because if they do an extra 5 minutes compared to probably most of you listening, they're going to get a better health benefit out of it, more proportionate benefit, because their physical activity levels are so low. The benefit is greater when you're at the bottom end. And in transport, we have largely missed that out historically, if we go back at least decades, because in the transport departments we look to get as many bums on seats or on bikes or walking or whatever as possible. We don't really care where they come from. But from a public health perspective, as a public health physician, it is my responsibility to help reduce health inequalities as well. So we need to help those people who do less to do a bit more. So the dose response curve is important. We shouldn't forget it. And if we can help poorer groups probably to walk more than anything, that would be very helpful in trying to reduce health inequalities. Another way of showing the health impacts and the risk of premature death is through a table like this. And this is largely one where I've explained to my transport colleagues that while we are very concerned and must do everything we can to reduce road traffic fatalities, we need to see it in a bigger picture, in a systems approach really, to understand the contribution of road traffic fatalities to a wider picture of premature death. So the graph shows just 3 diseases, main diseases. The number one cause of premature death in our society is coronary heart disease, and that bar is just a bit attributable to physical inactivity, as is the bar attributed to cancer, just to do with physical inactivity, and the same for stroke. So the numbers game, if we call it that, shows you that far, far more people are dying prematurely because of physical inactivity in the population. So it is arguable that actually what is more dangerous is probably being physically inactive. Being sedentary is more dangerous. Moving on a bit, one part of the good news for those of us working to WebTag in probably versions of WebTag, at least in the United Kingdom, is that the Department for Transport, anyway in London, when it thinks about value for money, will look at benefit to cost ratios. For every pound you spend, what do you get back? And we do tend to find that most walking and cycling schemes score over 4 to 1, which means they're very high value for money. Now this may be not news to many of you because there has been quite a bit of publicity about it. I'll just show you a couple of more slides. So one, this is a slide actually from a Sustrans Safe Routes to School scheme from a few years ago, and it uses the main categories in WebTag. So you've got decongestion, absenteeism, amenity, environment and accidents, as well as health. But you can see that most of that benefit is taken up by health. So we often find that about 2/3 of the benefit that we get from active travel when we're looking at it in economic terms is from health, which is savings from people being ill and dying prematurely. So lastly on, or last penultimately perhaps on this last section about economics, is just to alert you, if you don't know, there's a series of papers that Department of Transport have put out one of which came out in November 14, which I wrote for them, claiming the health dividend. And again, the reason why I gave it the title of claiming the health dividend is this point that most of the benefits are health benefits. But what we found overall in that review of the peer-reviewed and grey literature is that there's unequivocal economic justification for investments to facilitate cycling and walking, and yet if we look back at it, that this has been very much undervalued or not even considered in many transport assessments. I've already alluded to the fact that almost all studies report highly significant economic benefits, and the fact that the largest slice of the benefit is from the health aspect. Last but not least, perhaps on the economics bit, is just to flag up the heat tool, and I hope you all heard of the heat tool. If you haven't, I do encourage you to go and type in heat, WHO or World Health Organization, in order to not get a plumber's merchant, but go and have a look at the heat tool, because that is something you can use at your desks if you have a bit of the information that you need about walking and cycling schemes, which can actually generate benefit to cost ratios for you. And there are training sessions that WHO Europe and others can provide on that, but I hope that everyone is aware of the heat tool. Now, just moving on a little bit, in public health, we work to a range of public health outcomes. We have a public health outcomes framework, and there are 68 indicators in there. Now, a colleague of mine in London, Lucy Saunders, and I did look at these, and we worked out fairly easily that about 23 of them have got a transport dimension. So when we're talking to our public health colleagues, the connections with transport and health are quite clear in terms of the things that get public health people interested, because it meets the public health outcomes framework. I'm going to give you one example. So if you look at the arrow on this long list, you may not be able to see all the words, but the arrow is pointing to falls and injuries in the over 65s. So that is a big issue for the National Health Service. 1 in 3 people aged 65 fall each year, and when people fall, they tend to then have another fall and another fall, and end up increasingly involved in health service care, and they may need hip replacements. The obvious thing from a transport perspective is if we can help people as they go through the aging process to stay physically active, to just walk to the local shops or facilities rather than take a car, for example, we can both increase muscle strength, which is one of the things that stops people from having falls, and also help to maintain bone mineral density. So it's the density of your bones in your skeletal system, which itself is important, protecting against things like hip fractures. So there's an obvious one. We need, as a society ages, we need to help people to maintain muscle strength and bone mineral density, or at least slow down the decline of bone mineral density. And we can do that if we have more people walking in our populations than we currently do. Just finishing this little section now, one of the important areas, which I think is important particularly because of the cutbacks in local government, not least, is this idea of co-benefits. Co-benefits are that we do one thing in one area. Let's say we try to change the transport system to enable more people to walk and cycle. By doing that, particularly if we can get people to switch from cars, we may well be able to reduce carbon dioxide emissions. For clearly, on a global level, we're tackling climate change. We might also be able to reduce local emissions, vehicle emissions as well. We might, for example, if we improve our environments, get more children being able to walk and cycle to school. And that is important as a co-benefit, because we know now, and this is what the slide shows, the link between pupil health and wellbeing and attainment. We know that children, if they are more physically active, do better academically. Now, it's just because a little bit more oxygenated blood flowing through the brain doesn't necessarily mean they're going to turn out to be professors, but it just means they'll do a little bit better than they would otherwise do. So there's a co-benefit there. If we can actually help more children to be physically active, clearly it can help to tackle particularly the morning peak congestion issues and other transport related ones, but it can also help improve academic attainment. So moving on to evidence, I just want to talk about evidence a little bit because it is an area which is important to move forward with. And interestingly, we've been in an age of evidence-based public policy allegedly since at least the 1990s. Evidence-based practice first came out of medicine in the 1970s, but has taken a while to get a foothold elsewhere. But we do find that it is quite difficult working, particularly for those of you in local government, that evidence often plays a poor second fiddle to what are the dominant drivers, which may be clearly politicians' views, it may be business as usual, what we did yesterday, and it may be not recognizing that there are different levels of evidence, so that some evidence provided by consultants or others may only be of a certain level and robustness, but there is other evidence out there that may be far more robust and useful to us. So in medicine, we have started off with clinical evidence hierarchy. So what I'm showing you here is really, for those who are not aware, we have something called an evidence hierarchy, which does mean that you move up from the bottom level we show here, expert opinion and testimonials and observational case studies, right up to systematic reviews, and above that really meta-analysis, where you're pulling high quality evidence together from a number of studies. But systematic reviews itself means you have to, you're often randomizing, and below that you can see RCT, which means randomized control trial, and that's the best way to know for sure whether something we did led to a change. We often claim it, but most of the studies that are done by local authorities are not designed in order for us to be able to claim causality, although if it works, often you'll find counsellors very keen to claim it was because of what they did. We'll all know that sort of situation, but the overall point is that not all evidence has equal weight. Now, another aspect of this is that we do have out there a very large amount of good quality, robust research, which we as taxpayers have all paid for, but is often seemingly tucked away in the ivory towers of academia. And one of our tasks, if not the main task, is knowledge transfer. Knowledge transfer works both ways, but I'm particularly focusing on here, how do we get access to this really good quality stuff that unless you're an academic, you often will not know of, you won't even have heard of the journal necessarily, let alone the article, and if you even found the article, you might find it's written in such jargon you don't really understand it. So there are a number of routes to help us. One is the National Institute for Health and Care Excellence, which has produced 3 main publications: public health guidance relating to transport, so that's NICE guidance 8 on a built environment, NICE guidance 17 on children and active travel, and NICE guidance 41, which is on walking and cycling, which is most recent. And they are there, you can go and find them quite easily as sources of evidence about what works. And NICE guidance 41 actually was published alongside a local government association and Department of Transport briefing in order to try to make sure that that evidence was made available to colleagues in transport planning disciplines who don't normally go and look at NICE websites and NICE publications. One of the things I have done, principally because of what I've just said about the lack of knowledge transfer, particularly out of universities in dejargonized formats to practitioners, is someone that moved 8 years ago to having a foot both in academia and in local government, recognising that this information wasn't there, I decided eventually to start up something called essential evidence. There's 142 of these now, and you can see from the screen that there's a number of categories that we've created: one demand management and behaviour change, children, adults and walking, children and adults and walking, adults and cycling, public transport use, air and noise, safety, and public policies. I think there might be one more under there as well, and there'll be one more this afternoon when I get back to my desk. But those are they are one-page de-jargonized summaries to try to make sure that practitioners have got information to hand on a broad range of transport topics which relate to health impacts, and the ideal circumstances will be there you go and find the ones that are of value to you, and you cut and paste them into your committee reports if you're working in local government, and that really would be great. And that's what some of my colleagues now do, fortunately, in Bristol City Council. I'm glad to be able to report. Moving on then to finish up, a year ago, what was the Passenger Transport Executive Group, who've now been rebranded to be called the Urban Transport Group, they produced a report on the experience of the first 2 years of public health being back inside top-tier local government. I researched and wrote the report for them, and what we were trying to do was to ascertain whether the return of public health to top-tier local government would have meant that collaboration between these two differing professional groups had improved now they're back in one organisation. Theoretically, you can put forward a straightforward hypothesis that it likely should have done. Fortunately, the results from the survey responses we've got was that yes, there had been a really significant growth in collaboration between transport practitioners of various sorts, transport planning, urban designers, planners generally, and public health colleges, because they're back in the same organisation. It made it easier. They may have even ended up being in the same building. And when we looked at the detail of the findings, there was lots of good news here. So many directors of public health, those were the people we asked, gave medium to high priority of the health impacts of road transport in their work programme, and they said their teams had the opportunity to contribute to local transport plans and have participated in jointly funded projects and data sharing with transport colleagues. And the overriding thing was that they reported that active travel was the largest single area of collaboration. There are other areas like air pollution, which they worked on, but active travel actually dwarfed all the other areas. It was the area where people could see the need for collaboration between transport planners and public health colleagues. It didn't mean, however, that there weren't barriers, and we all know that the first barrier on this slide here is money. Money is very tight. Public health has been particularly hard hit this last year, so I would not encourage transport colleagues to go asking for money from their public health colleagues because they might get a rude response. Clearly keep talking, keep liaising, keep working together, but the money is really largely drying up if it hasn't done already. The perceived cultural dominance of the car, no big news story there. Bigger in the countryside than in cities, so that's also not a surprise story. And then again, this issue of differing standards of evidence, and I think there is a role for public health practitioners to offer more of our assistance on getting more robust evidence available to transport planning practitioners to help them in decision making. So I'm nearly through with my slides, and often when we start these things out, I ask people how many of them are involved in public health work, and so at that point most of the transport planners think not. They're transport planners, but actually unless you go out to be building roads, which I wouldn't encourage, it doesn't improve population health despite what the government is doing, that most of us are doing public health work. You don't have to be trained in public health to do public health work. For those of us in public health, it's often persuading our colleagues in other disciplines like transport and housing and education to deliver on the things that will improve population health. So if you didn't think it before, when this webinars finished, you may well consider yourself a public health practitioner and add that to your CV. So at that point, with a number of links that I'm leaving you, including, I see, an out-of-date Public Health England email address. Please don't use that now. I see that's a mistake. But there is the Travel West info evidence link, which will get me to essential evidence on the page. There's what is still called PTEG, but is now the Urban Transport Group, which has quite a few web pages on health. A link to WHO Europe. A link to a journal of transport and health. I'm one of the associate editors of a journal which started 2 years ago. You may find that useful. Some of the papers are free to download. And last but not least, sitting here in Sustrans, there is a link to Sustrans results on their work with the health sector. So I will stop there, and I hope that may have provided some food for thought. Thank you.
Okay, thank you very much, Adrian. That was fantastic. We've had a few questions, and if anyone else would like to submit some questions, when we can answer those also. So the first question is from Chris Brooks, and the question is, no mention of sociability or social capital or reducing traffic speed and increasing travel. So I suppose the question is, what are the additional benefits to the sociability of a city or a street through increasing active travel?
Right, so it's a very good point. It's just there's too many things to mention, Chris, in what I've said before, but we absolutely know that if we reduce vehicle speeds, we can help to improve social cohesion. I'm going to give you an example. So here in Bristol, one of the things I've been involved and responsible for is a 20 mile an hour program where we have rolled out 20 miles an hour across all of our residential streets and a few of our high streets. Now, 20 miles an hour is not predicated solely on casualty reduction alone. We have said the three things the 20 mile an hour program is predicated on is casualty reduction, but also improvements in social cohesion as more people feel able to perhaps come out and talk to their neighbours, and the street is not such a hostile environment. And the third one is increases in total physical activity time, because we hope we will see more people walking and cycling. Indeed, in our pilot 20 mile an hour program into inner city areas of Bristol, we did see some increases in walking and cycling, particularly at weekends. So that is not to, having not said it before, these are really, really important things. Aside from physical activity, which I've expressed how important it is for human health, social contact is really important. I'll often say, if you don't have friends and acquaintances, you'll be a sad bugger and you're likely to die young. So have friends and have acquaintances, because there is strong epidemiological evidence that the more friends and acquaintances you have, the less ill health you'll suffer from, and you are less likely to die prematurely. So we need to break down the barriers exactly that come from road transport to help strengthen our community cohesion.
Okay, fantastic. Okay, we've got a couple of questions on references and stats on slides 3, 5 and 7, so we can just check those afterwards.
Okay.
Question here is from another one from Chris, is are there any benefits to standing on public transport?
Okay, so standing, I think it's an issue in its own right. We're now moving into a different period in public health and medical research, which shows that Homo sapiens, even if we do 150 minutes, we need to spend much more of our lives standing. It is important for our bodies that we stand more often, and we will see undoubtedly, because there'll be a commercial edge to it, that there will be more companies offering standing desks as we move through the rest of this decade and into the next decade. I'm pretty sure that's going to happen, but we do all need to spend more time standing. So there is an irony of not getting a seat on the bus or the train or whatever and having to stand, in that it actually may be of value to us. But certainly there are metabolic and other related issues that are important, that we spend far too much time as Homo sapiens sitting down. So we do encourage, and physical activity and public health people tend to, at events, we often say, please get up and feel free to walk around a bit if you need. We won't treat it as you being rude to us, but it is a really serious issue, and the more evidence we have, the more strength of evidence we seem to have about the need to spend more of our day standing.
So we really should have done this as a standing
Yes,
webinar.
We should.
And if anybody's able to stand up while they listen, we'd encourage them.
Indeed.
Okay. So, question from Elizabeth Orton: does binge activity, such as running for 3 hours once a week, and an otherwise sedentary lifestyle, have the same benefits as more distributed physical activity?
Okay. So I don't actually encourage binge activity as you describe it, Elizabeth, but in relatively short time scales you can concentrate your physical activity into one section of 3 hours. I'm not sure in terms of wear and tear on the body whether that's such a good idea, but clearly our ancestors probably hunted the wildebeest or whatever they hunted across the savannas of Africa over fairly long periods of time. I think in terms, my job in public health, I suppose, is to look at the population level. You're right on the outlier edge there, so I'm not really worried about you if you don't mind. You know what the science says and you will no doubt adhere to it. It is really, when we look back at that dose response curve, we have so many of the population doing so little physical activity that increasing their physical activity by 5 minutes more would be important in its own right, and we have to find ways to get people to be physically active.
Okay. Have there been a question here from Marion Soderholm? Have there been any recent examples of successful collaborations between public health and the transport sector? I suppose these are either high-profile ones or ones that you are aware of in your work.
Yes, so I'm not sure where Marion is from. That sounds like a Swedish surname, but I'm not quite, I'm guessing. But if you're in England, certainly we're starting to see some of that through TfL, through some of the work that Lucy Saunders is managing to do with transport colleagues. But we probably haven't quite reached the campaign bit very well yet. There have been some big campaigns in the past, particularly in the Low Countries, some campaigns using public health messaging. Campaigns tend to work over a short period of time, and the question is, how long does the message last before you get what we often call regression to the mean? So we have to continue doing campaigns. I think we are in the UK certainly in the early stages. The difficulty with campaigns, to do them well, costs money, and that's one of the things we don't have at the moment. There have been some interesting campaigns in places like Sweden, linking public health messages, and other countries, but I think probably for this audience you'd want to hear about campaigns in the UK, and we just haven't had large scale campaigns. Often we find that interventions work best when we've done the physical intervention, we've done maybe some social norming and other work, and we've done some campaigning work, maybe some enforcement work for that matter as well, and multi-pronged interventions tend to work best. So it'd be good if we could do some joint campaigning work between the two. We haven't really had it at scale in the UK yet.
So in your experience, the multi-pronged approach of joining up changes to the environment plus information motivational campaigns is more effective?
So the research, the robust research internationally shows that multi-pronged interventions are likely to get the best effects. And you can go back and look at Vic Road campaigns in Australia in the 1980s, where they were doing seatbelt campaigns, drink and drive campaigns, police enforcement, and a whole load of stuff with a lot of strong media support, so everyone knew what was going on. and that seemed to have a fairly lasting legacy in terms of changing particularly driver behaviour in that case. So certainly multi-pronged approaches where you're doing environment, certainly if you're building cycling walking infrastructure, but you're also doing communication campaigns and behaviour campaigns to go alongside it. I think the cycle demonstration towns and sustainable travel towns also found that to be the case in the 2000s here.
Yeah. Okay. So we've got a question here about how to use the known benefits of health to motivate children, well, and anyone to travel more actively. Which I suppose is getting more into the behaviour change and motivation element.
Yeah.
Do you want to answer that, or should we focus on the evidence side?
Well, I think with children, and children are often in a captured situation, which is why we sometimes target children, because we get them when they're at school generally. Excuse me. The evidence around children is largely that children want to be more physically active, but physical activity is beaten out of them by the system. So I think we often will find, as I'm sure Sustrans has found in the past, that children are willing partners in wanting to be outside and wanting to be active. And I think it's our duty as adults to create environments which they can be physically active. It's a moral obligation to the next generation. It's a bit highfalutin, but I think it is important. And unless we do that, we are going to grow generations that are sedentary, and they'll be harder to change when they're adults. I don't think I should probably say any more than that.
Okay, we've got a question here from Tamara. So this is, as a professional working in an engineering consultancy, what advice would you give to translate this evidence into useful information for engineers, designers and planners? So I suppose that is a key question. The people who have joined in this call, we are like people who understand these benefits. How do we communicate them wider and have influence in our jobs?
Having worked tomorrow in a transport consultancy for 3 years, I think what might be worthwhile, if you can get the time and maybe even the permission to do it, would be to take some of the evidence that you can find and maybe do some promotion of it to colleagues in your own organisation. You could, for that matter, take my essential evidence, take a sample of them, the ones you think are most apposite, and run a lunchtime learning session on that. And if you're close to Bristol, you could even ask me to come and do it, or if you're further away, you even offer me money, and I'm likely to get on a train for that. So that's blatant promotion of my consultancy. So you could take the essential evidence series, and you could talk about that to colleagues about what it means and how does it affect their practice. And I think one of the things is opening colleagues' eyes to the fact there is a large evidence base out there they're not aware of. Maybe getting stuff on your own organisation's website about that might be a good starting point as well. I'm happy tomorrow to talk offline about that, because that's probably quite involved if you so wish.
Okay, brilliant. Okay, so a question here on the linkage between bus use and active travel, which we've talked a little bit about the physical activity benefits of public transport.
Yes.
But so this is John, who'd like had to be able to make a health argument.
Yes.
For maintaining bus services.
Okay, so hello, John. You probably know the answer to this anyway, but I'm going to tell it to everyone. So I did make a brief allusion to the issue of public transport use. We do have more and more evidence. I have a nice fat lever arch file, I think, at home, of peer-reviewed studies looking at the links between public transport use and physical activity. So going back a few years, there was a nice study in the US looking at a number of cities, finding that 29% of those who use transit, i.e. public transport, achieved all their physical activity requirements, 150 minutes, just by using transit, and many of the rest got a sizable proportion of their minimum of 150 minutes by using transit. So obviously it's the same worldwide. I know you talked about a rural area, but people that use public transport, perhaps commuting from rural areas into cities or whatever, will get more physical activity than most people that will drive. So there is a good case, particularly with an aging population, people that need to access the local towns, etc. This will also help them to maintain physical activity and social contacts as well, people on the bus. And social contacts is really important as well because of social isolation, which is a big issue, particularly in rural areas and with aging. So there's a number of benefits I think you could be arguing for more strongly than perhaps you might be already. And again, I'd be happy offline to supply you with some of that evidence if you don't have it to hand.
Okay, brilliant. Yeah, so I'll update Adrian's email on the slides and we'll send that around as well.
Yes.
So we'll send a follow-up email with the slides. So if you've been asking for the slides as well.
Mm-hmm.
A question here from Paul McConnon asking about involving public health element in a capital scheme bid. And this is talking here about using to encourage more new cyclists to use new cycling infrastructure.
Okay. So, Paul, I can only reiterate, I suppose, maybe if you'd have asked 2 years ago the same question, I'd have been, maybe I was naive, or maybe there was money there. In the past, back in the days of primary care trusts, there was an opportunity possibly for capital scheme support. But my understanding of it now is, and do ask, but I do think you're going to get absolutely nowhere. There is no money to give out. Public health posts are cut and frozen, otherwise frozen. We're in pretty dire situation, not least as a result of Jeremy Hunt deciding that we were not frontline and cutting an extra 200 million on top of the cut we're already getting. So I'm afraid I don't have any joy for you there. You might want to go and talk to Public Health England nationally about any contribution that they might be able to put in alongside DFT, which would be an interesting thing to do. But at a local level, unless there's something rather different on your patch, I don't think you're going to get the answer you're looking for.
Okay, a bit of reality biting there. Okay, so a similar question in terms of, I suppose, making the case for public health, well, and transport spending. So in terms of benefit to cost ratios and public health benefits, do infrastructure interventions perform better than behavioural change type programs?
So I think the answer is yes, they do tend to, and the reason for that is that human beings are fickle creatures. So if you build infrastructure, it doesn't go and wander off and decide to do something else. We often have to assume that when we do an intervention, people will, for the purpose of at least of calculating benefit cost ratios, if we build something or do an intervention, we encourage people to do something, that if they decide to do it, they will remain doing it, and that clearly is not always the case. And if it's only an encouragement to do something without building the infrastructure, that is harder, arguably, for people to do. So built infrastructure, we tend to be able to calculate that people are likely to use it for longer because it's physically there, and will do. We've got some good research recently from near the Cambridge guided busway with building some infrastructure. It takes us a little delay in the fact that people don't start changing their behaviour immediately, but we've seen after the first year we've started to see more people using the walking cycling infrastructure alongside the guided busway there. That's just a series of papers that CEDA at Cambridge University have been producing, which is available as open access, I'll add. But so the answer really is it's likely that the greater benefit is going to come from interventions where you have got a physical behaviour, a physical intervention. You might also have the behaviour intervention with it. It's always good to do both. But behaviour on its own, the risk is that people relapse. We know that anyway. It's harder.
Okay, right. So we'll just take one final question. Elizabeth Orton has said that through the smoking and drink driving, the culture has changed. So these activities are now antisocial, which has facilitated their reduction. How do we make inactivity antisocial? What can we do as local public health teams to change social norms?
Elizabeth, that's a really big, tough final question, because your guess may be as good as mine. I'll give a go at it now, but it's a difficult one. When we go back to seatbelts and we go back to drink driving, there were moral imperatives and ethical issue dimensions where we could point people out as doing an antisocial behaviour. Now, it may be described or felt by people listening in now that being physically inactive is an antisocial behaviour, but I think we might all have to agree it doesn't fall into the same category as drink driving. We do need to create new social norms, and that takes time. It also takes some money. We're trying to create a social norm in Bristol around there's no point in driving any faster than 20. You just get the next traffic lights a little faster and sit there, all the rest of it. These things will take time. There will be bigger societal changes which will help to bring about change. It may be the cost of bariatric surgery. It may be the cost overall to the NHS, particularly from diabetes, which is the one that's going to knock the NHS over financially faster than anything else. May trickle down into messages which mean we do encourage people to much more be physically active. It's difficult because there's also a victim blaming element here. Poorer people are more likely to be overweight, have less resources, educational, financial, and all the rest. And we did go through a horrible victim blaming period in the 70s and 80s when it's down to you, the individual, without understanding the wider determinants of your health. So we have to be careful about that. It would be good, though, to really promote physical activity as what Homo sapiens are designed to be, to encourage more people through a nudge style approach maybe to become more physically active because their mates are more physically active.
Okay, we're going to have to start drawing to a close there. It's a good question to end on, the kind of the wider societal challenges. It's been really interesting, and thank you very much everyone for all your questions. As I said, we'll make sure we share all the slides, and the webinar itself we'll make available as a recording. It just made me reflect. I'm having a look at the list of attendees, the mixture of health professionals and transport professionals that we've had joining us today, and also some of Adrian's comments around the challenges, particularly around funding and the difficult times, that how we can, or the importance of working together. And if, as we're stressing the importance of making changes to the physical environment, public health has to be working with transport and other teams that have the ability to do that. And the people making those changes have to speak to their health colleagues to understand the potential impact they can be having. So I think that, makes really clear how important taking that systems approach is to having an impact on these things. On that note of a kind of a systems approach, Sustrans has developed a workshop recently called Creating Healthy Places with the Soil Association, looking at health and transport, but also looking at the food system, and it's information which we'll be sending out on the Sustrans website, which has some information about there. And we'll also be sending out some information about the support that Adrian can provide also.
Okay, so I just say, well, thanks for listening, and please don't use the email address, which is now dead, by the way, for when I was at Public Health England, but we will send out the correct email address for you if you want to make contact with me.
Great. Thanks, Adrian. Thanks, everybody.